Hello, everyone. I am Rifat Manan from Baltimore, Maryland. Today, we are excited to host Dr. Elizabeth Thompson from Johns Hopkins Hospital. She is going to present about the cystic lesions of the pancreas. Dr. Thompson is an assistant professor of pathology at Johns Hopkins Hospital. So we would also like to quickly mention the Johns Hopkins Pathology Education Portal. It offers a host of educational opportunities. I would also like to inform you about the most recent prostate pathology app, so which has just recently been released. And there are other definitely pancreas pathology apps which are very popular. And also everyone, please feel free to join the Johns Hopkins email list, so you will get all the updates for the upcoming educational opportunities. So once again, we would like to welcome our viewers online. And for the first time viewers, so we would like to inform you guys that Pathcast is a platform to disseminate pathology knowledge base that we have started and we are still continuing. So we started, my good friend, Dr. Emilio Madrigal and myself. So we are hosting these lectures. And as always, you're most welcome to post your questions or comments during the lecture as comments in the chat window for Facebook as well as YouTube, and we will be happy to pass them on to Dr. Thompson. So with that, I would now turn the microphone over to Dr. Thompson. Thank you, Dr. Thompson.
Thanks, Rafat. I'm happy to be here to talk about pancreatic cysts today. So I'll just talk briefly for a second while I focus the scope. So I'm going to basically focus on neoplastic cysts of the pancreas today, both things that are true cysts, that actually have a true cyst lining, and things that maybe don't have a true cystic lining but are cystic on imaging, and so bring up a similar differential for clinicians as they're thinking about how to manage patients. So I think Dr. Ribang gave a lecture on the same platform a couple of weeks ago talking about adenocarcinoma of the pancreas. And while pancreatic pathology can be challenging, we're lucky in that it lends itself really nicely to sort of an algorithmic approach. And I think he went over how we use that to identify an invasive adenocarcinoma. And we can apply a similar kind of algorithm to cysts, where we first ask really simple questions like, is a lesion solid or cystic? Does it have a true cyst lining? And then if it does have a true cyst lining, we'll evaluate what type of lining is there and what type of stroma is underneath the lining. And that series of questions will really help us to properly classify almost any cyst you'll encounter in the pancreas. So I'm just going to kind of go through kind of a case-based approach with some recent things that have come through the service here. So this first case that I'm showing was a cystic lesions in the tail of the pancreas of a 54-year-old woman, and it was pretty large. It was about 8 centimeters, and had sort of on imaging sort of a honeycomb appearance, and had a a scarred sort of area in the middle of it. And this was a section from that resection. So we can see, if we start at the top of our sort of very simple cystic algorithm of is it a cyst or is it solid, you can see this lesion certainly is comprised of multiple cystic spaces of varying sizes. So then we want to go look closer at the lining and see what type of lining we have. And the big distinction in the pancreas that we'll make is, do we have a serous lining or do we have a mucinous lining? So that'll take us down very different types of roads. So this particular cyst is lined by very bland cuboidal epithelium with these nice, perfectly round, so centrally placed nuclei, virtually no atypia. The cytoplasm is sort of variably cleared, maybe a little bit pink in areas. Don't see any evidence of mucins. This nice, pretty pink to clear cytoplasm with very round nuclei is great for a serous lining. And so at this point, we're pretty much done. A cystic lesion with serous lined true cystic epithelium is going to be a serous cystadenoma. So we'll just kind of enjoy some more features of that. They often have a dense fibrous banding to them, which often coalesce in the middle. And sometimes you'll get both grossly and histologically a nice central scar, which correlates to what they saw on radiology for this particular patient. Serous cystadenomas are a little bit more common in women. They're almost invariably benign. There's very, very rare instances of them metastasizing. But typically, if a surgeon felt sure that they had a serous cystadenoma based on imaging, they might not even resect it. It could, in theory, could be left alone. One thing that does sometimes lead to the resection is if they grow very large in the head of the pancreas, they sometimes can just sort of find themselves wrapped up against vasculature. Even though they aren't sort of a truly infiltrative process, they can actually become unresectable if they get too close to vessels. And so that's another reason that they're sometimes resected. Classic morphology is this sort of microcystic appearance of multiply sized cystic spaces. I'll show you a couple of other variants. They can also be oligocystic, like this example here, where you essentially just have one central cystic cavity surrounded by your normal pancreas. And the lining from low power doesn't look like much. Then when we come down higher power, you can see this pretty line of just perfectly round nuclei, again with that nice sort of clear, in this case it's almost sort of a dusky kind of toned appearance to the cytoplasm. So this would be an example of an oligocystic serous cystadenoma. It can also have a more solid appearance, which again is one of the things on imaging that can be a little tricky. I apologize, I'll have to do a lot of refocusing. Some of these are all consult slides and things of various thickness. So I'll refocus for a second so we can look at this one. But they can be more solid, which, as I mentioned on imaging, can make it a little more challenging to pick up that it is a serous cystadenoma, and it can overlap with features of other solid neoplasms like a neuroendocrine tumor, etc. So here's a more solid area. You can see these nice little packed tubules, but again, they have the very same cytologic features, a beautiful round centrally placed nucleus with this nice clear cytoplasm. You can often see at the edge of these more solid areas, sometimes it's associated with a little more classic looking microcystic area, as this one is here, your more typical variably sized cystic spaces, again lined by those same very bland cells with clear cytoplasm. So because the cytoplasm is clear, you can ask, well, why is it clear? What's in there? It's actually glycogen, which can be a helpful trick. So if you were ever confused, you can do a PAS, and the PAS will beautifully highlight that glycogenated cytoplasm, the bright pink. And since it is glycogen, if you do a PSD or a PS with diastase, the glycogen will dissolve, and this is a PSD. And so here you no longer have that pink positivity, again confirming this was serous lining that had glycogen, which was what was creating that nice clear appearance. So again, no pink staining on that PSD. Typically the lining is, as we've shown, super flat, just sort of one cell layer, but you can sometimes see little papillations, areas like this, that are totally fine. It doesn't indicate anything unusual or bad about the behavior. It's still totally in keeping with a benign serous cystadenoma, but they can sometimes have slightly more complex areas to the cyst lining. I have another example here. Or just it's a little more complex, almost looks fused, kind of has the hint like it could be cribriforming, but again, that's all totally fine and can be seen in lots of serous cystadenomas. Little papillation there as well. Although typically you will see this nice flat lining. So serous cystadenomas can be associated with VHL, and then a good proportion of even sporadically occurring serous cystadenomas will have VHL alterations. So that's one way that people are hoping to be able to more definitively diagnose them, is to be able to potentially evaluate cyst fluid for VHL mutations. Since again, these are benign and could in theory be left in the patient and sort of spare them an unnecessary large whack of their pancreas. Something else that these lesions are very prone to that can be diagnostically challenging is that post-FNA, they can infarct and undergo really extensive degenerative changes. So here's one example of that degenerative change here in the center, where you can imagine how the needle went in here and then you had a lot of hemorrhage, and then you've had a ton of fibrous reaction to it. You have tons of hemosiderin hanging out here on the outside. In this particular case, there's still quite a bit of cyst left behind rimming it, And so you're still able to very clearly identify these nice round nuclei with a clear cytoplasm, variably spaced cysts. So even though you have all this associated degenerative change, there was still plenty of cyst epithelium to allow you to make that diagnosis. It can be much more extensive, and there's been cases where you've left with only maybe 5% of this whole cystic area actually contains that epithelium anymore. And I'll show you a couple of examples of a little more extensive degenerative change. So here's another one where you can see at low power, sort of dense hyalinization, in this focal area with lots of what looks like it should be hemosiderin, lots of sort of various stages of fibrosis, some more early little grayish tone fibrosis, and then again that merges into this more densely hyalinized pink scar. And higher power, again, you can appreciate all those hemosiderin-laden macrophages in there and just hemosiderin deposition within the tissue. And then surrounding that, you have this proliferation of cells, a little more of it here. And in some areas, it's gotten so compressed and sort of reactive, it's a little bit difficult to tell exactly what you're dealing with. They look small, but they're not as nice and round as we're used to seeing in those cysts that haven't undergone degeneration. They're a little bit darker. They've got some reactive change in them now, so some of them are a little bit angulated even. They don't quite have that nice round appearance that they did. And usually if you hunt around enough, you can find an area that looks a little more classic. So here's a larger cyst area. The cells look a little bit rounder, and you can appreciate maybe a little bit of clearing to the cytoplasm. Again, should help clue you in to the diagnosis. But it can be very tricky if most of the cyst is gone, obviously. A keratin can help highlight the epithelium that's there. If it's really obscured by all the inflammation, at least to help draw your eye back on the H&E to where you need to look. But again, usually you can at least find some focal areas with that still look nice, bland and round, and have that pretty clear to maybe light pink cytoplasm. Here's another area off to the side where you can really better appreciate, again, those nice centrally placed round nucleus with nice cleared cytoplasm. Again, with some of the cute little hemosiderin in the middle, just to remind us of all that we're in the middle of a degenerative area. All right, I think I had one more slide of degenerative stuff. Yeah, so here's just another example of this dense scarring, hyalinization that's gone on. You can see, again, you've got this little proliferation here. And when you go down and take a peek, you can appreciate, again, very small, bland nuclei with your nice cleared cytoplasm. That's your residual cyst lining there. Okay, so those are serous cystadenomas, with just a couple of the pitfalls of post-FNA infarction that can sometimes be a diagnostic challenge for them. All right, so the next, oh, sorry, I thought Spot was trying to hand me something. Okay, so the next case I'll show is this was a 67-year-old woman who had a very large cyst in the head of her pancreas. And it looked on imaging like it should be a serous cystadenoma. This is a slice of it. You can see you have some of this dense pink hyalinization and scar that we appreciated in some of those other sections we looked at. On imaging, it had that nice central scar and sort of a multicystic honeycomb appearance. What was unusual about it on imaging was that she also had duct dilation. And so typically, unless a serous cystadenoma has gotten so big that it's obstructing the main pancreatic duct, you usually won't get duct dilatation because they don't actually involve the duct system itself. And so that was a little unusual, and the size and location in combination with that duct dilatation led the surgeons to want to excise her cyst. And so certainly a good portion of it looked very much like we would anticipate for a serous cystadenoma. There were lots of degenerative changes, lots of scarring, which correlates with that central scar they saw in imaging. And then the lining, very simple, very bland, small round cells with cleared cytoplasm. So all seems fine for a serous cystadenoma. But then we get over to different areas of the cyst, and it has a very different appearance. If we go down and take a peek of those, now all of a sudden we've got this pretty mucin cap to some of the cells. We certainly have far more architectural and cytologic atypia than we typically see in a serous cystadenoma, even though, as we discussed, those little papillations could be fine. But the combination of mucin and this architectural and cytologic disarray makes us think we have something else going on. So now if we see a cyst with a mucinous lining in the pancreas, our two main choices are an IPMN, an intraductal papillary mucinous neoplasm, or an MCN, a mucinous cystic neoplasm. And so to distinguish those, we've already identified the mucin and the cyst lining, and so then we go and think about what we have in the stroma underneath that lining. And if we have just dense collagenous stroma, that's consistent with IPMN. And if we have a cellular, plump, spindled stroma that looks essentially like ovary, looks like ovarian stroma, that's what you'll see in an MCN. And so as we take a look at the stroma underneath this cyst, most of it is sort of variably hyalinized, and you have some areas that are a little bit more cellular. They look like very small, little thin spindle cells, more like fibroblasts. You never get a dense area of really plump spindled cells like you would see in true ovarian stroma. And so in this particular case, this lady had a main duct IPMN that was causing the dilation of her main pancreatic duct, and it was just acute collision with this serous adenoma that just happened to be sitting next door. They're not related, they're not really involving the same spaces even, because the serous adenoma doesn't involve the duct system. That just happened to be sitting next to each other. That's kind of nice. So IPMNs then are mucinous neoplasms. We define them as being greater than 1 centimeter in size and grossly visible, that involve the duct system, and they can involve both the main and or side branch ducts. So you could have an IPMN that just involves side branches and doesn't really involve the main duct, or you can have one that involves both main and side branch ducts. And they can really extensively dilate the duct system. As you can see here, this is a nice example of an IPMN. You see these long papillary fronds, abundant mucin. And you can see at low power how they're just really expanding these big duct spaces to the point where you really lose some of the normal architectural clues. You replace your pancreas that was at the edge really with fibrosis and some inflammation. Sort of maybe you might have an islet there, but you don't really see any more acinar tissue. It can really cause some significant, degenerative changes in the sides along the wall and then the adjacent pancreas. You can see, here's a couple residual small little ducts pouched off. Again, there's a residual islet with some inflammation, but they cause really extreme distortion of the surrounding pancreas. And so we classify them based both on the degree of dysplasia and on the histologic subtype. So we define sort of low/intermediate and high-grade dysplasia. Low to intermediate grade dysplasia, you still have sort of general organization of their cells where they may become pseudostratified, but they still line up neatly, kind of like a picket fence here at the bottom. You don't have total loss of polarity. You don't have any architectural complexity like cribiforming or micropapillary formations. So to kind of contrast that, when you get into high-grade dysplasia, you really want to see both cytologic disarray, where you have markedly atypical cells cytologically that have lost polarity, and you also would like to see architectural disarray in which fronds become fused, you see cribiforming, and you see maybe micropapillary features. We can go back to that first slide we looked at to get a sense of some of those more high-grade features. So in this particular cyst, you see these buds that are coming off that essentially no longer have a fibrovascular core within them. That's what we call micropapillary budding. Should be a high-grade feature. Some of that here. And that's really the probably most predominant high-grade feature of this particular cyst is all this micropapillary budding. You can sort of get a sense of a little bit of cribiforming here, a little bit of fusion, some mite sitting up high. There's not as much loss of polarity in this particular cyst, but we sort of have a lower threshold, within an IPMN than maybe compared to like a tubular adenoma of the colon in terms of calling things high-grade dysplasia. You sort of like to see cytologic disarray, but honestly, the architectural disarray is sufficient for me to call something high-grade. Again, you can see here this kind of complex fusion of some of these papillary fronds at the top and some of these little micropapillary buddings. again, all consistent with high-grade IPMN. So those are our levels of dysplasia, and then the different histologic subtypes that we recognize that don't necessarily have a lot of prognostic significance are intestinal, gastric, and pancreatic-biliary. There's some literature suggesting the pancreatic-biliary may be more aggressive, but there's also people who think that by the time a cyst is very high grade looking, it may simply look more pancreatic-biliary than intestinal or gastric anymore, and so it's somewhat confounding. This is a beautiful example of an intestinal type IPMN. They'll look very similar to a tubular adenoma of the colon. You get these nice pencil-like pseudostratified nuclei, and then again your sort of goblet-like mucin cap at the top. I'll show you an example of a more gastric-looking IPMN here. See, in this particular example, you sort of have a nice big pink mucinous cap that's sort of reminiscent of foveolar type gastric mucin. You even sort of have some of these little buds that look almost pyloric in nature underneath. But then you also sometimes get little goblet-like cells, and again, these can overlap, and things usually aren't strictly gastric or strictly intestinal. Often there's sort of a mixed histologic phenotype going on. I chose this slide also just to highlight that they can not only expand out the ducts within the pancreas, but then they can crawl up the main pancreatic duct, and this is a section coming into the ampulla where you can see the IPMN sort of slowly crawling up near the ampulla or whatever to empty into the duodenum. And they can do crazy things like grow all the way up, colonize the duodenal surface, and then even invade back through the duodenal wall. So they really like to go all over the architecture in the area. All right, so we talked about intestinal and pancreatic-biliary. And again, if we go back to this first slide we looked at, or sorry, we talked about intestinal and gastric. And if we go back to this first slide, this higher grade IPMN was also more in keeping with a pancreatic-biliary type cytologic appearance. And with the cells, instead of being quite as elongated and pencil-like, like you might see in the intestinal type, they have a little bit more of a shorter, more cuboidal appearance, more typical of a pancreatic-biliary type epithelium. All right. So the main thing that gets challenging with IPMNs is the question of invasion. About a third of these will harbor invasion, and we always recommend putting in the entire cyst for evaluation because the high-grade dysplasia and or invasion can be very focal, and it's that presence of invasion that's really going to drive prognosis for the patient. So it's important to recognize even a small amount of it. Now, because IPMNs really expand out the normal ductal architecture and really distort the normal architecture of the pancreas, they kind of sometimes take away some of the features we really like to use to evaluate for invasion. It gets pretty tough to tell what's infiltrative growth when you have your normal ducts so expanded that you've basically blown out all of your normal lobules. In addition to that distortion, you get a whole lot of rupture in these cysts that then creates a lot of reaction around it. And so those things all make it tough sometimes to evaluate what's true invasion and what's not. So there's definitely things that are very suspicious. Here's an area here that you have incomplete glands lined by mucin, which is very suspicious for invasion, but you can certainly have IPMN within a normal side branch duct that then ruptures. It gives you an incompletely lined area. So to me, it's not definitive. It's tough, however, to kind of make much sense here of a normal duct structure. But again, the other thing that makes that tricky is that not all of these spaces with mucin are actually lined by epithelium. So when you get, rupture of ducts in an IPMN, they spit out all this mucin. So you end up with huge areas of extruded mucin and reaction to that mucin. But if there's not definitive mucin floating in that epithelium to define a mucinous carcinoma for you, it can be very tricky to call invasion purely based on these incomplete glands and sort of areas of extruded mucin. But again, it's very suspicious as a type of area that you might think about cutting down, getting more levels, because you might end up with a more definitive focus just by evaluating it a little further. I'll show you some other slides that were suspicious, and I haven't cherry-picked slides. I've almost perfectly picked purposely picked some that have folds and sort of other artifacts that you normally see in processing, just to highlight that all those things kind of make it challenging too. And if you had a perfect slide in every way, a lot of things might be easier in a lot of organs, not just the pancreas. But here's another example where you have, these big cystically expanded spaces with sort of varying amounts of denudation of the epithelium, lots of reaction around it, both, you're going to get reaction to that compressive force from the expansion, as well as, reaction to your extruded mucin. Have little area, you'll find little areas like this, and with a little small gland, sort of partially lined by epithelium. Got 1 or 2 cells right here. Like, what is that little guy? The stroma here looks a little more concerning. But when you look at what's next door, you have this little lobule of chronic pancreatitis with these small atrophic ductules, sort of incompletely involved by this, neoplastic epithelium. So this could easily be, in keeping with another little lobule that just has some rupture associated with it. So again, while it's very suspicious, not for me diagnostic, and again, might be an area that you consider cutting down and seeing if it develops into something more definitive. Again, in lots of other areas, it's sort of somewhat incompletely lined glands, mucin that's sort of starting to track out towards fat, which again, the pancreas doesn't always tell you much because you can get fat sort of scattered throughout, but just enough that it's, this is a cyst that's making you uncomfortable, right? It's sort of doing a lot of things that are suspicious, but not fully diagnostic. What I really like to see to definitively call invasion is either, at least 4 or 5 sort of angulated small glands with desmoplasia off to the side of the IPMN that doesn't seem like it could possibly fit into a normal duct architecture. So that's 1. 2 would be perineural invasion. So one of these sort of mucinous glands, maybe it's some of your incompletely lined extruded mucin. If that's involving a nerve and there's epithelium with it involving a nerve, that's diagnostic invasion. Or if you see pools of extruded mucin with neoplastic epithelium truly floating within it. And that's sort of different from seeing extruded mucin that's lined by epithelium, which could also be consistent with a ruptured duct. I'll show you examples of what we really mean by truly floating in the mucin. I think you'll be able to see how that's different from these areas that make you very nervous, but maybe don't have anything definitive to hang your hat on in terms of invasion. So this now will show a couple that we think really truly do have at least focal invasion. So this was a frozen section of an IPMN. It can see it's very complex, of areas that have micropapillary budding, both cytologic and architectural disarray. So we feel comfortable even on a frozen section. This is a high-grade IPMN. And then this area in here just really draws your attention because it's starting to look very busy. There's a whole lot of inflammation. You get the sense that there may be something going on that you're getting an additional reaction to beyond just the cyst lining, expanding. And then you sort of come in here and there's these small little pink cells. At higher power, you can see we have a pretty large group of atypical cells, sometimes single cells, a little bit of mucin in them here associated with a desmoplastic reaction in between them. And while again it's small, it's still probably 10 or 20 times more cells in some of those suspicious areas we were looking at on that other slide. And on the permanent, then we were able to do a cytokeratin just to convince ourselves and highlight that there's no way these were strange macrophages or something. These truly were all epithelial. And the keratin really highlighted, again, the infiltrative and angulated growth of those cells. So this was an extremely small, less than 1 millimeter focus of invasion. The IPMN, it turned out to be the only one in the entire cyst, which is what was captured on that frozen section. So a couple of other examples. So here's one that probably looks very reminiscent to some of those incompletely lined glands. But then here you have just enough cells with too complex architecture to really account for a ruptured gland. And so this also was enough to call a very small focus of invasion here. It's a little more angulated, a little more infiltrative, almost trying to butt off here like into a single cell, as opposed to something that seems to be rimming a space. Now we'll look at a couple of examples, both of perineural invasion and of true neoplastic glands floating in mucin. And so that's what we mean here, is these areas where you have extruded mucin, and then instead of that mucin being lined by epithelium that makes you always question whether it's just a partial rupture or something of that duct, in these cases you have neoplastic epithelium. It's really floating in those spaces and sort of throughout the spaces, not just rimming the edge. And then there's even more larger areas of it here. See how that mucin is dissecting through the stroma and coming with it, again, around a nerve here, which you don't actually have epithelium around the nerve, but it's all very suspicious and in keeping with perineural invasion. Bumping up again here. You even have single cells here associated with it. So in these cases, you sort of have all the features you'd like to see. You have small groups of small glands, individual cells, you have an infiltrative growth pattern, you have neoplastic cells floating in mucin, and you have all those things associated with nerves. And so any one of those would have been enough, but in this case, we happen to get all three. But you can see in the background how it's still filled with all those other things that can make invasion really hard to evaluate. Lots of extruded mucin, lots of reaction to that mucin and rupture. But again, it's a reason to put through the entire cyst, because you could easily have only put through sections that just gave you those suspicious areas without any of these more definitive invasive groups. All right, we'll just show one more slide of some of this mucinous stuff, just to highlight that sometimes they can take over a nerve. It can almost be tough to identify the nerve in the background. Sometimes these little mucinous tumors, just because they're so just cohesive, they give a slightly different appearance sometimes in the perineural invasion, and often instead of rimming the outside of a nerve like we often see with the more traditional tubular adenocarcinoma, they often just sort of replace and infiltrate throughout the body of the nerve. All right. So those were invasion associated with IPMN. So IPMNs, like serous cystadenomas, also have sort of characteristic genetic alterations. They typically have KRAS and GNAS alterations. RNF43 is the next most common, and then when you have very high-grade lesions, you'll also accumulate some of this P53, P16, and sometimes even SMAD4 alterations, sort of right as you're at the juncture to developing an invasive carcinoma. I'll just make one comment about terminology. IPMNs are a little bit problematic in that they're officially designated as being greater than a centimeter. And so then the other precursor lesion we won't really talk about today that's only microscopically visible is a PANN, pancreatic intraepithelial neoplasm, and that's defined as being less than half a centimeter. So then this leaves you this obnoxious gray zone in between of what to call things that you maybe don't see grossly, but you see on a slide, or certainly seem more extensive. Maybe they have papillary formations. They just seem to be involving larger ducts than we typically see with PANN. So for that category in between half a centimeter to a centimeter, we'll often use the terminology incipient IPMN, sort of cover those regions. Sometimes, depending on whether we really only saw it microscopically or if it was tiny but still able to be grossly identified, if it's only microscopic, I might say large PANN/incipient IPMN. But they're even picking up, less than a centimeter cyst radiologically, and even on, an MRI sometimes now for patients that are maybe being followed for familial pancreatic cancer. And so it's nice to be able to, have some terminology that accounts for those in between lesions, things that really seem more extensive than a PANN. And so we'll use the terminology incipient IPMN for those lesions. All right, last slide on IPMN, just for fun, to show weird things that happen. So this was an IPMN that had a little bit of invasion associated with it there on the side, but it also was making bone in the middle. So you can see all sorts of funny things in these, because they'll sometimes have been sitting around for years in patients. Often, if they're not symptomatic, not obstructing or causing pancreatitis, until someone has an incidental scan for some other reason, they may not have ever known they're there. And so you'll sometimes see lots of calcifications in them, and in this case, that calcification went all the way to forming some organized bone within the cyst. All right, so next case, we'll switch gears a little bit. This was a 34-year-old woman with a big cyst in the tail of her pancreas. And when she had a resection, it looked like this. And so even from really low power, you can appreciate this nice mucin cap. So again, within our little cyst algorithm, we have a mucinous lining. And then, so we'll, to think about our IPMN versus MCN differential, we need to look at the stroma underneath that cyst lining. And it's, even from low power, really cellular. It looks very busy. So if we go take a look at higher power, you can see that it's comprised of this very cellular spindled stroma, and there are these nice, beautiful, plump, sometimes they're almost little round bellies to them. Again, reminiscent / really identical to ovarian stroma. And so this is a really pretty example of an MCN, a mucinous cystic neoplasm. So MCNs are almost exclusively seen in women, although nothing is 100%. It's about 90%, 10% women to men. They're much more common in the tail of the pancreas. In contrast, IPMNs are much more common in the head. And MCNs, again, typically more like a serous adenoma, tend to not communicate with the duct system. And so they can often go even longer before they're recognized because they're less likely to cause dilation of the main pancreatic duct, obstructive symptoms, and then eventually pancreatitis, et cetera. MCMNs can also have extensive degenerative change in them. They have a real propensity to bleed into themselves. And so you can occasionally not really have any lining to them anymore. You can sort of see this area where this was grossly the cyst lining, but when you look at it under the microscope, it's just comprised of fibrosis, macrophages, varying amounts of hemosiderin. We'll pass areas, I know we passed some on the other side already, of cholesterol clefting. And in this case, it just sort of extensively, even there's some of that nice cholesterol clefting, really extended out into the main pancreatic body, kind of far from where the cyst wall was. And it can be tricky then. In this case, we were lucky you had beautiful areas with your mucinous cyst lining associated with the stroma, so no diagnostic problem. But you can certainly get cases where you really have almost nothing but this degenerative stuff. And that's, again, where putting the whole cyst in will help you to identify maybe that focal bit of mucinous lining. I'm just highlighting here how all this degenerative change kind of blends into what seems like it might be a little bit of your cellular stroma here. The other thing you can take advantage of when you have all this degenerative change, and it can be tough sometimes to tell, is the cellular ovarian stroma or just really cellular fibrosis and reaction to this area of hemorrhage and stuff within the cyst wall, is you can take advantage of the fact that ovarian stroma and an MCN, just like in the ovary, will stain for estrogen receptor and progesterone receptor. And so in combination with putting the whole cyst through and hopefully finding a little focal mucinous epithelium, you can use an ER or PR to highlight the stroma. Not necessary for just general diagnostic purposes. It could be an H&E diagnosis, but if you ever are not sure if something's ovarian stroma, that can help. Another thing that can be cued is in younger women, the stroma can also respond to the menstrual cycle, and so it'll become luteinized looking under the influence of progesterone, and will become plumper and rounder, more pink appearing. And in those situations, sometimes they'll actually stain for inhibin, which again is not really diagnostically useful, just sort of cute to see. I brought a section from this case of the pancreatic neck margin because you saw how extensive that inflammatory response to the degenerative changes in the cyst was. It actually extended all the way out to the pancreatic neck, which that particular day gave us a lot of strife because we had recently had a signet ring cell cancer sneaking through another pancreatic neck. And so it was sort of nerve-wracking to see the sort of cellular infiltrate, but in the context, you have all this cholesterol clefting, some of it's very clearly foamy macrophages, and you have that, again, nice unilocular cyst. You can see the degenerative changes on it grossly. And so within all that context, you're comfortable this is all just a reaction to the cyst, but can be sort of, that reaction can be very dramatic and can extend kind of far from the cyst lining itself. MCNs, again, just like IPMNs, can be associated both with high-grade dysplasia and invasive carcinomas. So again, we recommend putting the entire cyst through, both for MCN, just to be able sometimes to diagnose, as we've mentioned, because it's just another example of how totally degenerated the lining can be, and that your mucin may be very focal. But so you want to put the whole cyst through to hopefully identify your actual cyst lining, but also to identify any focal dysplasia or invasive carcinoma. This is just an example of where the high-grade dysplasia was fairly focal and abrupt. So you sort of go along, have your nice, flat, barely even mucinous lining, and then all of a sudden you have these, lack of polarization, these tiny little micropapillary formations, fusion of adjacent little buds, and so you have very abrupt high-grade dysplasia within an MCN. MCNs also like to do funny things, like send off these funny little projections out into the cyst lumen. Again, sometimes just can be a little confusing to people because they sometimes get tangentially cut and makes the architecture look a little bit more complex. But again, I'm not sure why they do that per se, but it's just something we see fairly commonly. And again, you can see how a totally bland epithelium there, and it can really abruptly switch to this much more complex, higher grade dysplasia here adjacent to it. Because MCNs also have so much associated degeneration and fibrosis, they're very prone to sort of entrapping both normal pancreas as well as having funny budding of the cyst itself that can sometimes be confusing and concern people in terms of invasion. So you often see lots of budding underneath, but it's helpful to see how that ovarian stroma is still surrounding all of that, and there's otherwise no reaction to it. And from low power, it's still looking very well organized. There's nothing that's sort of budding off or really showing these sort of infiltrative growth. But again, you get these little, benign cysts, benign ducts sort of trapped in the fibrosis that can sometimes be a little tricky and can throw people off and worry that they have invasion. Let's have one other example again. If you have a little bit of budding and then it gets cut a little bit tangentially, again, can look concerning for invasion, but you can still draw nice round circles on these duct areas. Again, the ovarian stroma surrounds everything. You don't have any true invasive growth popping off of it. Another example of a little bit even scarier looking tangential embedding. But again, the fact that the ovarian stroma is really still encircling it kind of can clue you in that it's tangential. And again, you really don't have any reaction to a small group of infiltrative cells, and certainly no, extruded mucin with floating neoplastic epithelium or anything like that. But this issue of budding and having entrapped ducts within the cyst wall is really common with MCNs because they've gotten so hyalinized and fibrotic because of all the degeneration. It entraps both budding from the cyst itself as well as normal, just atrophic looking ductal epithelium from the pancreas. All right. So finally, just for fun on the MCN, I'll show a picture of a fun tumor that arose within this particular cyst. And so here's a much more juicy IPMN. Lots of epithelial proliferation, clearly high grade, tons of cytologic atypia, lots of architectural disarray. And then over here, you sort of have this funny little cellular area off to the side. When you look at higher power, you've got lots of really atypical looking, but sort of spindle to undifferentiated looking cells. They're not clearly making glands. Often they're just single atypical cells, and they're associated with these multinucleated giant cells that resemble osteoclasts. And on an adjacent section, actually had a more conventional looking invasive adenocarcinoma that again blends into this undifferentiated area with not as many good giant cells in this particular slide, but some some guys that were sort of reminiscent, that might be those osteoclast-like giant cells. So this was an invasive adenocarcinoma arising in an MCN that had a component of undifferentiated carcinoma with osteoclast-like giant cells. Now, what's particularly unusual about this case is that it really didn't seem to invade beyond that ovarian stroma. So it's sort of all still confined within the cyst wall. And so despite the fact that these undifferentiated carcinomas are typically very aggressive, in this case, if they're confined within the ovarian stroma, they probably do quite well. And just an unusual tumor arising within an MCN. Thank you. All right, so we have a couple more rare intraductal neoplasms to talk about, and then I'll talk briefly about some lesions that aren't really cystic but appear cystic on imaging. So the last two intraductal proliferations we'll talk about are an oncocytic version and something we call intraductal tubulopapillary neoplasm. So here's an example of another cystic lesion, obviously expanding out large ducts in the pancreas. But you don't have as much obvious mucin, and the epithelium itself is very, very pink. And then in many of these nuclei, you can appreciate this nice, pretty central macronucleolus. And so it has a very oncocytic look with all those features we associate with oncocytes in all locations: granular pink cytoplasm, round nucleus with this single centrally placed macronucleolus. And so the terminology for these guys is sometimes a little bit in flux. They were originally sort of grouped in as a variant of an IPMN, so like an oncocytic variant of an IPMN essentially. And people have sort of started to appreciate that they really seem to be distinct. They have very different genetics than IPMNs. And so people sometimes call them oncocytic intraductal neoplasms or intraductal oncocytic papillary neoplasms, but sort of separate from category of IPMNs. And then I think some people still really consider them a variant of an IPMN with oncocytic features. So again, the terminology is still in flux, but the crucial things about prognosis remain the same. Putting through the whole cyst, looking for high-grade dysplasia, the rules for high-grade dysplasia are still essentially the same. And then the fact that having invasive carcinoma associated with them is still what's going to drive prognosis. Very rare, but just another type of intraductal lesion to be familiar with. The last intraductal thing I'm going to talk about is called an intraductal tubulopapillary neoplasm, which again has distinct genetics from an IPMN, and again is very rare. And they're comprised of these small, often dark cuboidal cells with a combination of sort of tubular and papillary architecture. And sometimes the papillary architecture is really less prominent than the actual tubular formation. This is an example of one that might be very, very tricky because there's just not that much epithelium. But you sort of get a sense you don't see the obvious mucin that you see with an IPMN. It doesn't look intestinal, it doesn't really look pancreatic-biliary, it doesn't really look gastric, but you could certainly look at it and be like, this is just a really, really weird IPMN that I have. Then you can get a sense that the nuclei are kind of smaller, darker, more cuboidal than an IPMN, but again, lacking the mucin you'll often see even with a pancreatic-biliary type IPMN. And then in other areas, you'll typically get much more dramatic growth. These things often grow with sort of a pushing architecture, almost akin to DCIS of the breast or a papillary carcinoma of the breast. If we go and look, apologies for a little bit of formalin artifact on this slide. Look at the architecture again. You can appreciate how it's really interlocking and anastomosing tubules. And then sort of rarely you get more kind of papillary formations. Mucin is really not prominent. The cells are very hyperchromatic, kind of small cuboidal to round. And they really expand out the ducts to the point where it can be extremely difficult, even more so than an IPMNs, to tell for sure what's invasion in these neoplasms. This particular one, when you get to the edges of them, you sometimes get more traditional looking infiltrative growth here with desmoplastic response, sort of angulated, irregular glands. But probably a lot of this larger pushing growth is also invasion, but if someone tries to pin you down and ask, well, exactly how many centimeters is it, it can be pretty tricky. A higher percentage of these, when people have looked at large series, and the large series are really maybe like 30 to 40 cases, because it's still rare, a fairly large percentage of them will have invasion, but they do much better than IPMNs with associated invasions. They really seem to have distinct behavior. Here's another example that I think even more strikingly resembles DCIS of the breast. You can see again how the architecture is really comprised of these, predominantly of these beautiful little tubules. You'll often see central necrosis within these nests. And again, they sort of expand out with this pushing growth that it's hard to sort of pick out any one of these guys and say for sure that it's invasive. But again, areas like this, where you have these small little infiltrative nests, are very suspicious, and you feel sure that there's no way this is an invasive growth. You have single cells budding off. Looks very similar to those little pockets of invasion we looked at with the IPMN. But overall, it can be pretty tricky, and unfortunately in the pancreas we don't have a marker like we do in the breast, microcellular markers or basal cell markers like in the prostate, and so we just have to, again, evaluate the whole cyst and do our best to try to estimate how much is invasive. But again, even though these commonly have invasion associated with them, they do seem to do much better than invasion arising from other cystic lesions. All right, so I got about 5 more minutes. So I wanted to show a couple of examples of things that are not true cysts, so that they don't have a true cyst lining, but appear cystic on imaging, and so can cause that that differential to come up for the clinicians. So this first example is a lesion in a 20-year-old female, a solid and cystic lesion on imaging. It was resected and looked like this. It's comprised of these sort of small, fairly bland cells that are very discohesive, so they're sort of falling apart, and they're sort of falling apart and rimmed by these areas of sort of myxoid to mucoid change in the stroma. And in some areas, though, they even sort of surround blood vessels, sort of giving a hint like maybe they could have been papillary in nature. This particular example also has some degenerative changes to it, some cholesterol clefting. Again, here's some examples where those discohesive cells are sort of falling apart, admixed with blood. Interestingly, you can see this lesion, while from low power seemed very well demarcated in the most part, does infiltrate into the pancreas, but it does what we call insidious infiltration, and that there's no reaction really whatsoever to the surrounding pancreatic parenchyma. And if this was an invasive ductal adenocarcinoma, you'd have dysplasia, you'd have lots of chronic pancreatitis associated with it, but really the acinar tissue, even when it's totally encircled by this neoplasm, looks perfectly happy. Here's a nice example too of the question of, is this a papillary neoplasm falling apart? Here's a nice little blood vessel sort of rimmed by these cohesive cells, again with some of that mucoid matrix. So we'll look at some other examples of the same lesion. So here's another example. This one sort of has more dramatic areas of vessels sort of rimmed by this, in this case, a little more hyalinized to mucoid-looking matrix. And very bland cells, very discohesive. Here they are sort of falling apart around these blood vessels, given the appearance of papillary growth. And again, you almost think you're looking at papillary fronds. So this is an example of a solid pseudopapillary neoplasm. And so we call it pseudopapillary again because none of these are true papillary fronds. It's just the tumor cells falling apart of these, off of these areas of stroma that happen to have the vessels closely associated with them. It gives the appearance of being a papillary neoplasm. So cytologically, they're characterized by having small, bland oval cells, often have nuclear grooves to them. If you're lucky, you find some beautiful round pink hyaline globules. And these degenerative changes are very characteristic, seeing these big areas of foamy macrophages, cholesterol clefts. All of those really help clue you in that this is a solid pseudopapillary neoplasm. Here's again, beautiful cholesterol clefts. If you have the opportunity to, it's always great to get a smear of these because it really highlights these beautiful pseudopapillary formations and can be really useful in helping to identify them unfrozen. So you can see really beautifully in this example how you have these discohesive cells that are falling right off these areas of stroma with blood vessels and leaving behind this sort of pseudopapillary formation. And you can see in the background of the smear often highlights the beautiful nuclear grooves that are characteristic of this neoplasm. So on imaging, sometimes these are again common in young women, and so sometimes this solid and cystic brings up the differential of like an MCM with a lot of degenerative change, or even a cystic neuroendocrine tumor. Those are often what the clinicians are thinking about. These are characterized immunohistochemically by abnormal beta-catenin labeling, as they have characteristic alterations in the gene that encodes for beta-catenin. And so you can see the surrounding pancreas, your beautiful normal membranous labeling for beta-catenin, and then in the neoplasm, this abnormal nuclear and cytoplasmic labeling. Again, that helps with your differential for neuroendocrine tumors. Neuroendocrine tumors won't have that labeling pattern. Solid papillary neoplasms are also positive. This is a different tumor example, but are also positive for CD10. And pitfall is that they can be positive both for CD56 and synaptophysin, which can cause some difficulty if you're considering a neuroendocrine tumor, but they'll be negative for chromogranin, which should help distinguish those two entities. So I think 1 p.m. I think I'll stop there. And thank you guys for listening and watching, and for Rafat for having me.
Yeah, thank you, Dr. Thompson. Thanks for your nice discussion on the cystic lesions of the pancreas. So we have a few questions online, so maybe you would like to answer them. So there is the Dr. Irshad from Pakistan. So he has this question that I think, can cystic lesions be detected on CT in the early stage?
Yes, they can. So it actually, there's a whole clinic here just dedicated to following people with pancreatic cysts that have been detected on incidental CTs. And so you have categories of patients who have abdominal CTs for other reasons, and they can detect sometimes very small cystic lesions, sometimes even under a centimeter, depending on where they're located and who's reading them. And then obviously patients may present with pancreatitis or with pain, and they may find the cysts for that reason. But yes, absolutely, they can find them pretty small. It's hard to know sometimes if it's early or just a small lesion that's never grew, but they can definitely see them when they're pretty small. And it's a pretty big management challenge, because how to follow those patients, how often they need to be followed, can they ever be released if you've gone 5 years and the thing hasn't grown, and you don't have main duct dilatation. So most people in the US follow what's called Sendai criteria, which take into account things like the size of the cyst, the amount of main duct dilation to determine who needs to go to resection, etc. But yeah, they can definitely detect pretty small lesions at this point.
Thank you, Dr. Thompson. There is one more question. So this is from Anshuman in India. So he is asking, is there any role for SMAD4 in IPMN?
Yes, I will sometimes use that. We talked a lot about cutting down suspicious areas and sort of looking for more obvious areas of invasion, but we will sometimes use SMAD4, sometimes SMAD4 and P53, because if you have like a group of atypical glands sort of at the edge of an IPMN and you're not sure if they're invasive and don't feel like you can totally get there on H&E, if those are SMAD4 lost, or DBHC and have upregulated P53, and that combination makes you feel strongly that those are going to be invasive, because typically when they've sequenced IPMNs, usually SMAD4 and p53 are either very, very late alterations in an IPMN, or you don't see them at all until it's an invasive tumor. And so particularly if you have the background IPMN, you see that that's still SMAD4 intact, and you see a couple of small glands infiltrating off that have lost SMAD4, that's going to be supportive evidence for an invasive cancer.
Thank you. He also has this question. So is there any preoperative diagnosis and biopsy possible for the cystic lesions, or it is contraindicated?
Yeah, so they try to biopsy them all the time. It's sometimes challenging to get sufficient material from them to give them a good answer. If I'd had more time, I was going to talk a little bit about the notion of using genetic molecular analysis on cyst fluid. That's sort of the big interest now, is to be able at the time of an endoscopic ultrasound to aspirate fluid from the cyst and sequence it, because you could really, in theory, take advantage of the fact that these cystic lesions have really distinct molecular alterations. So if you find a VHL mutation and nothing else, you feel very good that's a serous adenoma in the proper radiographic and clinical context. If you find a beta-catenin alteration or alteration in the gene that codes for beta-catenin, that helps you for solid pseudopapillary. There's combinations of the mutations you see in IPMNs and in MCNs that can lead you down those paths and even help you suspect that there's actually a high-grade component to that lesion. And there's a lot of interest in doing that. University of Pittsburgh has a panel available clinically where they can do a certain number of evaluations, and there's also a large panel in development here at Hopkins to look at a number of alterations, as well as things like aneuploidy and those sorts of issues within the cyst fluid. So yeah, hopefully that's going to be the future, to be able to not just to avoid surgery, but to make sure people get to surgery at the appropriate time. If you have a non-diagnostic biopsy, but you have p53 alterations in your cyst fluid and those sorts of things, you want to be able to triage people to get surgery who need it, as well as hopefully spare people surgery who have a really benign acting neoplasm. Okay.
Thanks a lot. Thanks, Dr. Thompson. So you would be happy to know that you had viewers from different countries like Spain, Brazil, India, Pakistan, Lebanon, UK, and of course, US. So thanks to all the viewers for tuning in, and please don't forget to subscribe to our YouTube channel. And we have our next session coming up on May 9th. That would be on mesenchymal tumors of the kidney by Dr. Matosa. Thanks again.
All right, thank you
so much. Thank you, Dr. Thompson.